Good afternoon, everybody. I'm so glad to be back with you again to do another one of our 2-hour webinars. I'd like you to please, if you can, pay a lot of attention today because we're going to be talking about an extremely important subject. And I usually like to lead into that subject with a short little seminar of about 10 or 15 minutes before we get going. But I don't like to do that right at the beginning because right now there are not that many of you there. In about 10-15 minutes, my assistant Josh, who helps me every week, will let me know that there's a large number of people on the forum. And then I'll give you a little introduction and we'll get talking because our topic today is the ovarian protocols used for stimulation, how critical they are to success or failure in IVF. And I'm going to emphasize this over and over again in many ways. What we talk about today is the one thing that is most common to everybody undergoing IVF and to people undergoing ovarian stimulation even without IVF. So, as soon as Josh tells me he's got 1 or 2 questions ready to go, we'll get going.
Nothing just yet. Only a few people just in here. Welcome, welcome, guys. If you guys are just now scrolling, Dr. Scher is answering questions on IVF, and today's topic is stimulation protocols. Go ahead and leave a comment in the comment section here, and we will answer questions. I'm going to go to your...
Okay. Got anything yet, Josh?
Yeah, I have one here. It says, I am 8 DP 5 DT. Since yesterday, I have been cramping like my period is just about to start. I have the same exact feeling and pain. I keep hearing this is normal, but I'm a bit scared. I've already had 3 failed transfers. This time, I have higher dosages of hormones plus Clexane.
Yes.
Clexane. Are these cramps normal?
Well, you know, it's very subjective. Obviously, you're very apprehensive. You've been through this before. Hasn't worked for you. So the issue is it going to be a failure again? And of course, that anticipation can make you feel all kinds of things. The truth of the matter is that all that matters in the final analysis is the pregnancy test positive. And then if you go on a couple of weeks, you end up with an ultrasound where you can see a baby with a heartbeat. When you get a positive pregnancy test, you have a chemical pregnancy in place. Once you can see it by ultrasound, it's a clinical pregnancy. And then when the pregnancy develops further, and you can then pick it up by a clinical examination alone, then you can tell if it's a clinical pregnancy that's progressing normally. But symptoms at this stage are very subjective. I can tell you good signs, and they don't have to be there. I want to repeat that. They don't have to be there. Thousands of women have none of the symptoms I'm telling you about. But if they're present, it's a good sign. If your breasts feel full and engorged, if you feel bloated, if you have frequency of urination, you're running to the bathroom more often than you usually do, these are often signs that something's going on hormonally. And the commonest hormonal going on is that something's trying to embed, and that root system of the embryo is already starting to produce hormones that are making you feel these symptoms. Again, if you don't have them, don't be disappointed because it may mean nothing. That's why I say in the final analysis, you've got to wait. And it usually takes about 8 to 10 days after the embryo is transferred before you can get an inkling of a positive pregnancy test. And then you need to repeat it 2 days later because the levels should double every 2 days in the first few weeks of pregnancy. After you get to about 6 or 8 weeks, the levels don't double every 2 days anymore, they slow down. But that's another story. Right now, I wouldn't be overly concerned about cramping. I'd just wait it out a few more days, do the pregnancy test, blood pregnancy test, and see if you have a positive HCG.
I'm going to answer this from May Eve on TikTok here. It says, best protocol, 40-year-old AMH 14.3, PMOL, AFC 17, type 1 diabetic, partner low sperm motility. Any advice?
We're going to talk about this later on, but you've got a normal AMH. 15 is normal. Anything below 10 is concerning. 10 to 15 is a kind of a grey zone. In the units you're describing, clearly you live in Canada or you live in the United Kingdom or somewhere else. In America, we don't measure AMH in picomoles per liter. We measure it in terms of picograms per milliliter. And there the normal is over 1.5. Above 2 is great, 1.5 to 2 picograms per milliliter is a grey zone. But you have a normal AMH, but you do have another issue that you're confronting, and that's age. A woman, as I'm going to explain later on in some detail, and as I don't want to go into too much now, a woman's born with all the eggs she's ever going to have. And she'll start running out of those eggs as they get used up more and more. And when they drop below a certain level, then her AMH starts to drop because her ovarian reserve is declining, which in other words means the number of eggs remaining in her ovaries is declining. So clearly, you've still got plenty of eggs, very good for the age of 40. But what you don't have the ability to influence is how those eggs affected by time. There's a wear and tear factor, so your eggs decline in quality as you get older. It's inevitable. Nothing we do can change that. So that at the age of 40, instead of, as it was 5 years ago, where 2 out of every 3 of your eggs were good and could make embryos upon fertilization that could make a baby quite comfortably, at 40 only 1 in 5 is normal. And that's a natural effect of wear and tear in your eggs. So time is a big issue, and you've got to get going. I'm sure you are already proactive. Clearly, age is a factor, and your ovarian reserve as measured by the AMH is also a factor.
I'm going to answer, this is a larger question. It's got 3 comments here, so hopefully I read it all correctly here. It says, I was going through IVF before egg collection. They canceled my cycle due to ovaries not responding. It says, quick enough, a month later I fell pregnant naturally. Could this be down to the IVF meds previously? I also had period before, I think they said failing, pregnant naturally, and I'm currently 14 weeks pregnant.
Well, first of all, congratulations. It goes to show that you will ovulate on your own even if you've got resistant ovaries. But your ovaries may be resistant because you are running low on eggs. Doesn't mean that when you ovulate you can't get pregnant, as you've just demonstrated. But if you're running low on eggs, the protocol used for ovarian stimulation is very important. It could be that in your case you never received the ideal protocol for ovarian stimulation, something I'm going to be delving into in a few moments in some detail. So stick around for about another 10 minutes and we'll be deep into that seminar where you understand all these things better.
Alright, I'm going to go up here. That's a good question, just came through. Miss Cherry says, can a 44-year-old do IVF kindly?
Yes, of course you can. But the older you get, the smaller the number of eggs that are going to be normal. As I just mentioned, at 35, 2 in 3 eggs are normal. And the eggs are the most important determinant of whether the fertilized egg or embryo is going to be competent to make a baby. So at 35, 2 out of 3 times you've got eggs that can make a baby. At 40, only 1 in 5. And I'm afraid at 44, only about 1 in 12. But the problem is that as you get older, you also run out of eggs. Your AMH goes down because your ovarian reserve is going down. And when your AMH level goes down and you've got fewer eggs, there are fewer to choose from. So if you were 35 and you had 5 eggs, good chance 2 of those are going to be normal. When you're 40, if you've got 5, you're lucky if 1 is normal. And at 44, it's very unlikely even 1's going to be able to make a baby, because the effect of, as you get older, the quality of your eggs through wear and tear are being compromised. And so it becomes very important. We can't reverse the biological clock. We can't put the toothpaste back in the tube. We can't make you younger to make your eggs better. We can't change your ovarian reserve if it's already decreased. All we can do is to make sure we don't damage the eggs that are in the ovaries, the eggs that are available in that particular cycle. And if there are normal ones in there, we don't use a proper protocol that's different for every woman, you won't get eggs that can make embryos. Even if it was a good one, it'll be corrupted. So yes, your chances are much lower at 44. But here comes one very important point, and I'm going to mention it again later. And that is, if you get a normal egg, and we know it's the egg, more than the sperm that plays the main role in determining whether you're going to get a competent embryo that can make a baby. So if you end up with an egg that is normal and does make a normal embryo, and we test it by doing PGTA, which I again will talk about later, and that embryo's got all 46 chromosomes present, which has got to have to be able to be competent to make a viable pregnancy, then that embryo will make a baby almost as easily as if you're in your 20s. Only the chance of getting to such an embryo declines rapidly as you get older because of that wear and tear effect, and also influenced by how many eggs you can produce each time, which is a function of your ovarian reserve as reflected by your AMH.
Alright, if you guys are just now scrolling and coming across our live, Dr. Scher is answering questions on IVF, and today's topic specifically is about ovarian stimulation protocols and which one is best for you, why some can cause failure or success, and we're answering questions today, so drop it in the comments here below. If you guys are just now scrolling or been here for a minute, go check out our link in our bio. We have multiple resources. Dr. Scher just finished writing one of his articles for you guys today. It's exclusive for you guys only who are in these live streams for these days and these sessions. Go check it out. There's 2 options in there. You can fill out the link in bio. You get 2 free ebooks and articles, and then if you'd like to have a conversation with Dr. Scher, there's a 4-minute questionnaire on there. You fill it out and then he gets right back to you. We're going to answer a few more questions here before he gets into his seminar for today. We're going to answer user 73. They said, what is the best way to detox your body from high-dose stim medication?
You automatically detox. When you stop it within a couple of days, it's out of your body, gone out through your urine. By the period of about 2 weeks after you finished, all the effects of those hormones are usually also gone. So I don't think there's any specific detox you need. Stop the meds, get on with normal living. A couple of weeks from there, you're back to normal. And within 1 month, your ovaries that were stimulated and may have produced cysts or follicles that are nothing more but very small cysts, those will have disappeared and gone, and the effects will be gone.
Alrighty. We'll answer a few more questions here. Drop your comments in the comment section below. We'll answer as many questions as we can here. Let's see. I'm going to answer Lindsay here on TikTok. They said, can you tell us what the leading cause for chemical pregnancy is? I had 2 fully healthy live births.
The commonest cause of chemical pregnancy is something wrong with the embryo. It's not the only cause. You could have a chemical pregnancy because the uterus was not receptive to a normal embryo. That can be due to anatomical causes in the uterus, the thin lining, irregular cavity, or immunologic factors. But by far, 80% of cases where you have chemical pregnancies, the reason will relate to the embryo being abnormal. Abnormal means a lot of things, but the commonest cause of an abnormal embryo is chromosomal. And each cell in the human body has 46 chromosomes. The embryo is also going to have 46. If it's got even 1 more or 1 less, then you have an embryo that is incompetent because it's what we call aneuploid. It's got an irregular quota of chromosomes. Such an embryo will usually not attach, or if it attaches, it will attach briefly, be lost as a biochemical pregnancy or as a miscarriage a little bit later on. But the bottom line is, you've got to have a normal embryo in order for that embryo to attach properly. And that's the commonest cause.
Lindsay also said, will it affect future pregnancies? How thin of the lining would make it difficult?
If the lining is under 8 millimeters in thickness, and Lindsay, I was the first one to show this in the 90s, I don't think there's an IVF program in the world that doesn't appreciate that you've got to have a thick enough layer of soil in a planter box for the roots of the seed to gain attachment. Seed is the embryo, the soil is the uterine lining. And if it's not thick enough, there's nowhere for the roots to go, the embryo will start attaching and be lost, usually before you even know you're pregnant. Or you'll find out that you have a positive pregnancy test and lose it soon after as a so-called biochemical pregnancy. Or it'll attach for a while, come loose, and you'll miscarry. So the lining's got to be at least 8 millimeters, preferably over 9, on the day of ovulation, when you have a home ovulation test that tests positive in the urine, or when you get a trigger shot of HCG to get a cycle going and the eggs matured, or when you're doing a frozen embryo transfer at the point you start taking progesterone. And when you do that, it's got to be at least 8, hopefully with a triple line appearance as well, but preferably over 9. Under 8, I would not put embryos in the uterus, because the chance of losing it is great. But the bigger problem is, God forbid you get pregnant and that baby hasn't got enough place for the roots to grow and develop a healthy placenta. So then the lifeline for the baby is compromised, and now the baby doesn't develop properly, and you give birth to a child that is not as optimally developed as it should be. Nothing could be worse than that. So, if for a variety of reasons, the most important one of which is to get a good implantation so that a healthy lifeline or placenta will develop to result in the birth of a child that has optimal potential going forward into life. That's the goal of what we do, not just getting women pregnant.
All right, we'll answer like one or two more questions here, and then we'll go right into our today's topic. AM96 has a good question. It says, "What is an empty embryo?" Question mark.
You mean an empty sac? We call that an anembryonic pregnancy. Imagine you're planting a seed in your backyard. I like to use this analogy because it applies. That seed, if it grows, will grow, break through the soil, germinate, break through the soil, and form the plant. Well, that seed is the embryo. A plant can not break through the soil but still survive for a short period of time and then fade away. That's what happens with an anembryonic pregnancy. The implantation begins, but it can't sustain the growth of the plant. It can't sustain the growth of the embryo. So what you've got is a sac that should contain the embryo, but it's empty. Yet there is a placenta or developing root system that gives you a positive pregnancy test. And then you do an ultrasound, you see an empty sac. That is usually also due to an embryo abnormality, but it can also be due to something wrong with the ability of that embryo to attach. And so it can be implantation or an embryo, but in most cases, it's the same cause as the lady who asked the question before you. The same cause as having a chemical pregnancy or a miscarriage. The commonest cause is still something wrong with the embryo, usually chromosomal.
All right, Dr. Shaw, I'm going to answer this question here, and you can go right into your seminar today. It says, "What protocol should be used with failed implantation?"
Depends what the cause of the implantation problem is. If there's failed implantation because the embryo was abnormal, you've got to find out why the embryo is abnormal. Is it your age? Is it genetics? Have you had the wrong protocols, as we're going to be talking about in a little while? What was it that made the embryo abnormal? On the other hand, was it the uterine lining that wasn't receptive? And I've mentioned, it could be a thin lining, could be an irregular uterine cavity, or it could be immune problems in the uterus that I've spoken about at length in the past. So it can be a lot of things that causes that. So there's no one answer to that question. Here's where I'm going to start off now on this seminar. In light of what you've just asked me, I want to clarify. I've gone out of my way in the last 2 or 3 months to present you with very important topics that can play a very critical role as to whether you're going to be successful or not in IVF. I've spoken about conditions such as what causes failure in IVF, what are the factors that influence success or failure. I've talked about things like endometriosis. I've talked about a variety of topics, but I want you to know that the final analysis, if you want to go back and read or view a video on these topics, you can find them. We now, as of today, have just launched onto a podcast, which you can get through Spotify. You can go to our bio, my bio, and you can find a link that gets you onto YouTube, gets you through Spotify onto
Apple Music, YouTube, Google Play,
and all kinds of things. So you can always watch these videos if you want to. They are there, and you can watch them at your leisure. But it's so important that you know that they are there. Also, and I want to reiterate what Josh said, my goal here is not anything else than to educate and inspire you. I hope to be able to look you across the ether here and know that you're saying, well, that's the message we got. My job is to inspire you so that you understand what is available to you to help you achieve your goal. And that is why I give every single person online here today, access to a free book, 2 free books that I wrote with my partner, Dr. Drew Tortoriello. He's the medical director in our program in Midtown Manhattan, the Shared Fertility Solutions, SFS. These 2 books, and I've written many books as you can see here, lots of books. 2 books come to you, the most recent ones, free as downloadable ebooks. All you got to do is go to my bio, click on the link, and if you click on that link, automatically you get the books free. Nobody's going to solicit you or chase you. This is simply to give you that information, and the books are very comprehensive. One book is 300 pages long. It's like an operational manual. You can go to the index and read up on any topic. Each chapter stands alone. You don't have to read the whole book to get the gist. The other book is on one topic that I've been very instrumental in as one of the pioneers, and that's the field of clinical reproductive immunology. Because immunologic factors can affect not only if an embryo will attach and implant, but it can also affect the ability of a pregnancy to stick. And women who've got immune problems will often lose their pregnancies through the repeated early losses, biochemical pregnancies or miscarriages. So that thin book is only 50 pages long, but I give it to you because I wrote it 4 years ago. And the reason was that there's not much out there for you to read on this. And many doctors just ignore it. They think to themselves, it's not that important, but it's critically important for those of you that have this problem. And 20% of you will have this problem. So I urge you to get those books. All you do is go to bio, click on that link. We'll send it to you immediately as downloadable ebooks, and you can start reading selectively. In addition to that, as Josh just mentioned, for those of you that feel you'd like to talk to me, and there is no pressure, there is no solicitation, all you do is click on a different link there, and that other link, you'll be able to get access to a short 4-minute questionnaire. I urge you to do it while you're online with me now, because there's no downside. Nobody's going to chase you. All you do is get that questionnaire, fill it in. The moment you fill it in, it comes to us, and we'll get back to you to find out if you are interested in discussing your situation with me. I'm sure you're going to realize at the end of this discussion that I may be able to help many of you that are spinning your wheels. And if you're spinning your wheels and you're not getting traction, there's nothing worse than to keep doing the same thing over and over again, hoping for a different result. Usually it's because no one's found out what the cause of your wheel spinning is. And I can help you. So if you're interested, click on that link, get the questionnaire, fill it in right now. And then that questionnaire comes to us, we get back to you, and if you want to, only if you would like to, you can have a consultation with me for an hour online, and we can discuss your case, after which I'll send you a 25-page report with everything in it, including your history and all of the supportive literature that I've written over the years that will help you better understand your situation and get to the bottom of it. Okay, let's get going. The topic for today is probably the most important topic I've spoken about so far, because it affects every single one of you that are taking fertility drugs for procedures like IUI or IVF. It has to do with how do you and how does the protocol that you're using to being stimulated affect your ability to get pregnant or not. The article that I wrote that you also get free of charge with the books when you click to get the books is one on this very topic, and I just finished writing it about 15 minutes before this talk begins. So please get it. It's very important for you to read. Now, in order to understand this, the first thing I want to say is, like anything in biology, there's what we call a bell-shaped curve. There are those people in the middle of the bell that are going to respond in an average way. They comprise about 80% of the biological sample. On either side, you get the bunch of people that don't respond like the usual. For those people that are in the middle of the bell when it comes to fertility treatment with fertility drugs, it really doesn't matter how you get stimulated, you're going to usually do okay. Now there are cases where you're in the middle of the bell and something else is wrong that is weird, but most cases will respond to a recipe approach that you can find and that your doctor has been able to learn and properly implements in all of his patients or her patients. And it will work well for the people in the middle of the bell. But God forbid you're outside the middle and you're in the sides of the bell. You will not respond, and it will make things worse in many cases. Let me understand and let me help you understand why that's the case. For women that are first of all, let's put it this way. Two important factors will affect your success and your ability to conceive through IVF, more than anything else. One of those is your age, and the second is how many eggs are in your ovaries. Remembering a woman's born with all the eggs she's ever going to have. She uses them up in batches as she goes along through life. And when the number of eggs remaining in the ovary, think of the ovary like a bank where you put your money. When you run low on funds, you get advised by your bank manager to take out less funds every month to stretch out what you've got and make it last for longer. Your eggs are like those funds in your ovaries. And they run lower and lower as you use them up. When you get to a certain point, and that differs from woman to woman, usually occurs around your mid-30s, it can occur much later or even earlier, the number of eggs remaining in your ovaries falls below a certain threshold that differs from woman to woman. When it drops below that threshold, your bank manager, your ovary, starts to meter out fewer eggs per month, and there's nothing you can do about it. You've got to deal with whatever you get every month, and the number of eggs will decline as you use up more and more of them. So, as you go below that threshold, which varies from woman to woman, you start getting diminished ovarian reserve, DOR, which we can measure in a number of ways. But the most standard way is to measure a blood level of a hormone called AMH, anti-Mullerian hormone, in your blood. It's produced by those little early follicles in your ovaries. And when the anti-Mullerian hormone drops below 1.5 nanograms per milliliter, or 10 picomoles per liter if you live in Europe or Canada or Australia, then you are having a sign that you've got DOR, diminished ovarian reserve, developing. Fewer eggs are going to be available. No matter what we do, we can't change that. That's the way it is. But there's another factor besides your ovarian reserve which plays an important role, and that is age. The younger you are, the higher the percentage of the eggs that are in your ovaries, and the percentage of the eggs that we remove at IVF are the chance of them being competent, meaning able to produce a healthy baby. To be competent, when you ovulate them or they're removed, they've got to have a very fixed, regular number of chromosomes, which is half the normal number of all the cells in our body. Our normal body cells have 46 chromosomes. So 36 hours or so before you ovulate it or it gets removed after a trigger shot with HCG. And those eggs have to be exactly 23. Of course, the sperm has to be 23 as well. So when the sperm and the egg come together, now you're back to 46, which is the normal human genome. To do that, the egg divides in half. Divides in half because you get something called an LH surge, which you measure in the urine and the dipstick, which shows a color change, which tells you that your pituitary gland in your brain is releasing LH, which sends your eggs into that division that divides them exactly in half. So you end up, if it's a good egg, competent egg, with exactly 23 chromosomes upon ovulation or extraction at IVF. The sperm divides into 2 sperm. So what was 46 in the sperm now makes 2 sperm of 23 each. 23 from the sperm, 23 from the egg, you're back to 46. And that embryo has to be 46. But the biggest determinant of whether it will be is the egg, not the sperm. Because there's so many sperm that congregate around the egg. The egg has the ability to select the one it wants, and if there's some good ones, believe me, it'll attract the good ones. But there's only one egg. So if that egg's not a good egg, no matter what the sperm's like, it can't make a good embryo. So the bottom line is, the egg has to be 23 chromosomes. And that requires that in that 36-hour period, where it goes through this reproductive division of dividing the chromosomes in half, it has to go down from 46 to 23. And if it doesn't reach exactly 23, we're in trouble. So, it's extremely important to understand that the older the woman gets, the older she becomes, the less the ability of those eggs to go through an orderly division, dividing the chromosomes in half. We call that reproductive division or meiosis. And if that doesn't occur in an orderly fashion, the eggs will be chromosomally irregular. We call that aneuploid. And the resulting embryo will be incompetent or aneuploid as well, meaning it's got more or less than 46 chromosomes. So the egg has to be normal. And the older you get, the greater the difficulty in that happening. Nothing we do can change that. The reality is that at the age of 35, 2 in 3 will have that ability to come out with exactly 23 chromosomes. At 40, perhaps 1 in 5. And at 45, perhaps 1 in 25. These are rough numbers, but what they give you the idea of is that there's a slippery slope. Age is an inevitable effect on egg quality, and ovarian reserve means that if it's going down and you've got DOR, you've got fewer eggs. And if there's a smaller percentage of those eggs that are normal, because you're getting older, you can see how that compounds your problem. Which is why, in the middle of that bell-shaped curve that I told you, a woman with ideal opportunity to get pregnant through IVF has to be under the age of 35, but certainly not over 40. And she has to have an ovarian reserve that's normal. That tells us there's enough eggs available, but if she's older than 40, doesn't mean she can't have a normal egg, it's just less likely. We may have to look harder, we may have to do the egg retrieval more times to get to the good egg. But guess what, ladies and gentlemen? The most important determinant when it comes to women that are outside that bell-shaped curve, that are older or have diminished ovarian reserve and have got more problems coming up with good embryos to make a baby, the biggest consideration for those women that fall into that category is how we stimulate the woman with fertility drugs. We can't make her younger, we can't reverse her ovarian reserve, but we can protect those eggs, the 1 in 5, even the 1 in 25, even the 1 in 10, whatever the number may be, that have the potential to be normal. Because if we use the wrong protocol, we'll corrupt the ability of those eggs to come out being chromosomally normal with the potential to make healthy embryos. We'll corrupt that effect if we do nothing to protect them during stimulation. And the biggest mistake by far the doctors make in IVF is by using a one-size-fits-all protocol for everyone. Using a recipe approach. Because for the young woman in the middle of the bell, she may get away with it. But for the woman that's older or the woman that's got diminished reserve, both or either of those, she's going to end up with poor quality eggs. And then you get told there's something wrong with the quality of your eggs, which is not wrong. If the wrong protocol is used and the eggs aren't good, they're still poor quality eggs. The question should rather be, what can be done to protect the eggs that had the potential to be normal by using the right protocol? And if you don't do that, and if you don't get that message loud and clear now, many of you that are out there with diminished reserve, or many of you that are older, are going to keep spinning your wheels till someone says, you know what, there's nothing much we can do, you need an egg donor. Or you need prayer, but it's not going to help you. Bottom line is, you've got to use an individualized and strategic protocol to get the optimal quality of egg that is going into that cycle. Because we don't shuffle the deck, we don't deal the hand, we play the hand the good Lord deals us every month. And every month there's a certain number of eggs which will diminish as your ovarian reserve goes down. And our job is to rescue the eggs that are good, treat them good, and let those eggs be normal. Because, as I told you earlier, if we get an embryo that's normal, and it's usually the egg that determines it, not the sperm, you've got an embryo that is chromosomally normal, we can do tests to make sure it's normal. And the test we use is called PGTA, pre-implantation genetic testing for aneuploidy. Now, how do I know that? Dr. Tortoriello and I were among the first people in the world to introduce PGTA testing into the field more than 20 years ago. It's now used all over the world, proudly so. We had the option when we discovered this major game-changing breakthrough. We had the chance to take that knowledge, sit on it for a year or two, patent it, and make a lot of money. We made the right choice, which was to do what we needed to do, to be honorable, ethical people. Get it out there to the hands of people that can then apply it and make it help the human condition. We did that, proudly so. And so now it's available all over the world in over 4,000 clinics. And it's believed that there have been over 40,000 babies born worldwide from embryos selected because PGTA, which is a biopsy of the embryo, when it's well advanced and gets to 5 or 6 days development, becomes what we call a 100-cell or more blastocyst. We biopsy some of those cells without harming the embryo itself. And then we test those cells by PGTA to see if it's normal. If the embryo is normal, regardless of your age, regardless of your ovarian reserve, there's about a 60% chance that that embryo will produce a pregnancy that's viable. And that's what happened to the one lady that asked the question earlier on. She said she didn't respond to fertility drugs. Probably she had diminished reserve. But when she ovulated on her own, the egg she released was likely a normal one. And that normal one gave her the pregnancy that she's now gladly and happily encountering. So I want to make that point extremely clear. So then the question arises, what are the factors how can we influence the environment of the ovary that makes it better for the egg? So please, I plead with you, listen to this. Because then you'll understand what I've just said and why it's so important. The ovary of the woman has two compartments. Follicles, which are the fluid-filled spaces that harbor the egg, and they have connective tissue around the follicles. When you do an ultrasound, you see a dark area, rounded dark area, that's the follicle, and then a white perimeter around it. That white perimeter you see around the follicle is connective tissue or stroma or theca. It produces male hormones, testosterone, androstenedione, DHEA, and testosterone is the most important one. That testosterone is formed in that stroma, that connective tissue, through the activity of a hormone in your brain formed by your pituitary gland called LH, luteinizing hormone. LH causes the stroma to produce the male hormones. They are then carried into the follicle in a bucket brigade fashion to reach the cells that line the inside of the follicle, called granulosa cells. Those granulosa cells process the testosterone through the action of the other sister hormone of LH, formed in the pituitary gland called FSH, which is also present in the fertility drugs you get. It converts the testosterone through an enzymatic process to estradiol, which is an estrogen. And as that happens, the granulosa cells multiply. The follicle distends with fluid into it. There are more granulosa cells. Estrogen gets pumped into the circulation. We measure the size of the follicle and the level of the estrogen in your blood as indications of how the follicle is responding and growing. But for there to be estrogen to be formed, there has to be testosterone formed by the stroma. For that to happen, there has to be some LH produced by the pituitary gland. But here comes the bottom line. There cannot be too much testosterone. If you overproduce testosterone, you get the reversed effect. It gets into the fluid of the follicle and interferes with the ability of that FSH hormone to convert the testosterone to estradiol. And the follicle stops growing. The egg stops developing properly. And you end up with something we call premature luteinization. It's all in my article that I'm giving each one of you free, along with the 2 books you can get from the bio. Please get it. So the testosterone in excess causes premature luteinization, corrupts the development of the follicle, corrupts the development of the egg, slows down the rising of estradiol in your blood. And those eggs in that follicle, the eggs in the follicles of that ovary, are now going to be more likely to be aneuploid after the HCG trigger, after you trigger the woman. Remembering when the eggs have developed fully, they have still got 46 chromosomes. What we've got to make them then do is divide the chromosomes in half. And that happens through the trigger shot. We use something called HCG, which comes as an injectable form from a urinary-derived HCG, or it comes as a recombinant HCG called Ovidrel. If we give the right form of trigger at the right time with the right dosage, that egg that happens to have the potential to be normal will end up with exactly 23 chromosomes and be capable of producing a viable embryo. You can't make one that doesn't got that capability to do that, but you can make the one that does. So the key to ovarian stimulation, which is not as important in the young woman in her early 30s with a normal AMH, who's got good eggs because she's got plenty of them and she's young, and her age hasn't yet adversely affected their quality. Those women will usually get by even with the recipe and protocol that most doctors use over and over on everybody. But if that same protocol is used on women who have got this diminished ovarian reserve and are older and are overproducing LH in their pituitaries because they're older and because they've got diminished ovarian reserve, you will not protect their eggs because too much LH will cause too much testosterone, premature luteinization, and now the eggs are more likely to be abnormal. So, what is the key? When you're dealing with women that are outside the bell-shaped curve, that are older, that have diminished reserve, you've got to use a protocol that regulates the amount of LH-induced testosterone delivered to the follicle. If you don't, or you use something where too much LH is released, or you give too much LH, by the way, LH is present in menopure. Menopure is a gonadotropin. It's got equal amounts of LH and FSH. You don't want to ever give too much. I never give my patients more than 75 units of menopure ever. So if you don't allow the woman to get drugs, and if you give them Follistim, Gonal-F, Purigon, those are DNA-related, recombinant DNA FSH products. So they don't have a lot of LH in them. So if you focus on using those products and a very little amount, but some, menopure, then you will not get this effect of premature luteinization. I can't overemphasize the importance of this. So, what don't you want to do? You don't want to take too much menopure-containing, LH-containing drugs like menopure. You don't want to use protocols that cause the pituitary to produce more LH than it already does. And if you use protocols we often call a flare protocol, or a microflare protocol, or a short protocol, where the woman's given Lupron in the early stage of stimulation, that Lupron that you give early on after you start the stimulation will trigger more LH production, result in more testosterone, and corrupt the eggs. So for women who are older, or women who have diminished ovarian reserve, you don't want to use flare protocols, which I never use, because I'm scared that some woman, even though she's younger, may be in a situation where she's more sensitive to the LH that will be expunged from the ovary at exactly the time the eggs are coming out of the starting gates and starting to develop and corrupt those eggs. So flare protocols are something I never use. And you don't want to give drugs in older women or women with diminished ovarian reserve, such as Clomid or Letrozole, because they expunge more LH out of the pituitary as well. And I've just told you, too much LH in an older woman or woman with diminished ovarian reserve who's got low AMH is a bad news situation. It'll cause more production of testosterone and cause premature luteinization in the follicle. And those of you that have been told, and I don't believe it's wise advice you were given, that you, if you're older or you've got diminished reserve, should use a gentler form of ovarian stimulation, mini stimulation, or low-dose stimulation, or even natural cycle stimulation, where you just use your own natural cycle to produce the eggs, have to understand that women who are older, or women that have got diminished reserve on their own are overproducing LH, and do nothing to regulate how much LH is around, the eggs they produce are going to be of poorer qualities. And when you add drugs like clomiphene, or you use letrozole in a mini cycle to try to give less follistim or gonal-F or less stimulation to make it more gentle, are being giped, because these drugs will even increase the LH even more. And especially if somebody's being given gonadotropins in the form of menopur in high dosages, where you're taking additional LH coming at you in the menopur, are also in a bad situation. That's why I don't believe that women that are older or women that have diminished ovarian reserve should ever use mini IVF or natural cycle IVF. Because if you're led to believe that's going to help you, you're being disillusioned. You're actually making matters worse, because you're doing nothing to regulate your own production of LH, and you're doing nothing to prevent more LH reaching to you by the clomiphene you're being given or letrozole. So, how should you be stimulated? There are many ways of doing it. I'm not going into every stimulation protocol. The book I'm giving you, the article I'm providing to you free, that every single one of you should click on the bio and get them free without any other, you owe us nothing for it. It comes free. So please read it. And these books over here, two of them, the newest ones, are available to you on the website, but through the bio, immediately delivered to you as downloadable free ebooks. And for those of you that, from listening to what I say, are starting to see yourselves in this situation and realizing that you are spinning your wheels, the most important thing is not how I feel, how your doctor feels, but what it does for you to have a family. And to do that, you may need some additional advice, a different approach to protocol that is individualized to meet your needs. I have developed protocols over the years that are now used all over the world. The best protocol for the woman in the middle of the bell is what we call a long pituitary downregulation protocol with Lupron, but the Lupron started well before the cycle of stimulation begins, so there's no more LH around by the time you stimulate it. The Lupron doesn't begin when you start the drugs to stimulate you. That's a flare protocol, which I don't think is good. But if you use a long downregulation protocol with Lupron, if you have got normal ovarian reserve and you're in your 30s, you should do pretty well. Get eggs, most of which will be good quality, can make blastocysts or advanced embryos that by PGT-A testing are normal, and only one of those in your uterus, put in the uterus after you know it's good, provided you test to make sure that the uterine lining is receptive. We spoke about this earlier, and I mentioned it in a previous podcast that I did, and that is that if you've got problems with implantation, it doesn't help if you plant a good seed or embryo in the soil that is not receptive, the uterine lining being the soil. You've got to deal with that as well. So evaluating you to see how you should be stimulated is part of the story. But 20% of you will also have an implantation problem in the uterus. That needs to be evaluated immunologically and anatomically before you go into a cycle. Certainly before you go into a transfer of an embryo, be it fresh or frozen. So from that perspective, I can't emphasize how important it is. Another protocol we use, and I use, is called an antagonist protocol. Lupron is an agonist. The antagonists of things like ganirelix, cetrotide, and orgalutron, they block LH, which is what you want. But it all depends on how you give it. In the conventional mode, people get given fertility drugs, and when they're along a week or so into the cycle, now they get given ganirelix or cetrotide or orgalutron to block LH. That will block the LH, but here's the problem. It only starts blocking the LH a week into stimulation, during which time you've already started with fertility drugs, your eggs are already starting to respond, and you've now getting exposure to LH-induced testosterone. Early on in the cycle, when the eggs are at their most vulnerable stage, again, for the young woman in the middle of the bell-shaped curve, she'll probably do okay. That's why a lot of women get pregnant even with those protocols across the board. But that same protocol, where you start getting the antagonist late in the cycle, about 7 or 8 days in, will be subjected to the possibility that her LH could have gone up in that week, compromised the egg, and now you've damaged the egg at its most vulnerable stage, and it's probably not going to recover in most cases. So using that conventional antagonist cycle with suppression late in the cycle is not the best thing to do, in my opinion. It will suffice in the younger woman with normal ovarian reserve, but not in the woman that's older or a woman who's got diminished ovarian reserve of any age, because she's already overproducing LH. So that's important. The third protocol, the one I use in most of my patients, is called the agonist-antagonist conversion protocol, because you start a week or so before the period on Lupron, which is an agonist, and as soon as the bleeding starts, you start your fertility drugs and you switch from the agonist to ganirelix cetrotide or Galutron, which is an antagonist. So we call the protocol the agonist-antagonist conversion protocol. By overlapping them in that way, the agonist with the antagonist, you avoid the fact that the LH may rebound and go up as soon as the cycle of stimulation begins. So that's why I start the antagonist on the first day of stimulation and continue it all the way to the HCG, and restrict the amount of menopure that I give the woman to no more than 1 vial or 75 units, building up the FSH with the Follistim, Gonalev or Puragon. That's called the agonist-antagonist conversion protocol, the details of which you'll find in the articles that you read, that I'm sending you, and also in the books that I'm making available to you. The agonist-antagonist conversion protocol is one I use for women who've got diminished ovarian reserve that is moderate of severity. Some women have got very severely diminished ovarian reserve, an AMH of less than 0.2. Women like that need their granulosa cells, the cell that line the follicle where the egg is attached onto and that produce estrogen, given a boost. And in those women we do something called estrogen priming. So now we give you the Lupron. When the period starts, we give you some estrogen to prime the cells of the follicles to be more responsive to the stimulation drugs, and then we begin with the antagonist and the stimulation drugs. That's called an agonist-antagonist conversion protocol with estrogen priming, and you'll find that in the book and in the articles we're giving you as well. There are a couple of others I just want to mention. We don't have time unless you ask me about it during the course of this presentation, but it is in the article I'm sending you. There's another approach to stimulation that helps a lot of women that produce few eggs, and those are the older women and women with diminished ovarian reserve, or women who've got diminished ovarian reserve and as a consequence of that the eggs are compromised. It's called a duo stimulation. In this situation, we stimulate a woman as soon as we've removed the eggs. A few days later, we start another cycle of stimulation before they even have their period. This duo stimulation is becoming more and more popular. It may benefit some women who are older, women who are going to receive cancer therapy that can harm their eggs and need to get as many eggs out as possible quickly, women who produce few eggs, or women who want to bank their embryos. In that situation, we can speed the process up by doing 2 cycles in 1 month. Do a cycle of stimulation, and then 3 days after the eggs are harvested, go back and do another one. My article that I give you explains that in some detail and tells you why it shouldn't harm your eggs. But it isn't a major breakthrough. I mean, if you do 1 cycle and then wait until the next period begins to start the next cycle, you're not going to get poorer quality eggs. But you're also not going to compromise your eggs by doing duo stim cycles. So read up on that. There's another protocol that we developed, Dr. Tortoriello and I, called EZ IVF, playing off the words easy. And that means that it's for women that have got perfectly normal ovarian reserve. They're young and have got a lot of eggs, where we only have to use a smatter of the fertility drugs, which are expensive. So we don't have to give a lot of Follistim or Gonalev or menopure, very low doses. And we only have to give it every 2nd day. The woman will still respond well. We call it EZ IVF. If you read that paper I'm giving you, it talks to that as well. EZ IVF is a great way to stimulate women who are young with lots of follicles and a normal AMH, which is perfectly fine, and therefore I've got good ovarian reserve. There are other protocols as well. We could talk about the use of things like human growth hormone in the cycle to augment the response of the egg. But remember, human growth hormone can't take an egg that's abnormal and make it normal. That's epigenetically determined. Nothing we do can change that. No supplements, no fertility drugs, no procedures known to man can make a woman make more eggs or change the quality of the poor eggs into good eggs. All we can do is protect those that are good, would otherwise be corrupted if we use a one-size-fits-all protocol. Now, I'm not going to go any further with this. I'm going to open up for questions. But I hope you all understand, every one of you, why every single person on this live feed should basically go and get those books free without any pressure on you. Click on the link in the bio. Get the paper I've just written on the importance of individualizing the protocol for ovarian stimulation. This is the hallmark of good IVF. All the rest is adding tinsel. This is the most important determinant. Of course, we also have to make sure that when we put the embryo in the uterus, the lining is receptive, and that's implantation issues. And you'll find videos on that I've done through my webinars with you in the last few months. You'll find on YouTube and through Spotify or through Google, whatever you go to, or Amazon, wherever it may be. So we're going to stop there now. Hopefully now, with the assistance of Josh, I can now direct myself to specific questions. I'm sure there are many of them.
Yes, there are. There's so many questions. Thank you all for commenting and waiting for us and being patient. We appreciate it so, so much. If you guys are just now scrolling and joining the live stream right now, Dr. Scher is about to answer some questions on IVF. So go ahead and comment them in the comment section below, and we'll answer out individual questions. If you guys were watching that whole live, as Dr. Scher has said, he's got free articles, free ebooks, and multiple resources all available for you guys in the link in bio. Just go to his profile, click his face at the top here, click the link that's in our bio, and it'll take you right there. There'll be two options for you. One option will take you to a page where it has the free articles, free ebooks, and all the resources you need. And the other one will take you to a questionnaire. You fill it out, it takes 4 minutes of your time, and Dr. Scher will reach out to you within a few days here and get back to you. We're going to answer some questions now, Dr. Scher said. So go ahead, comment your questions if you have anything relating to stimulation protocols or why IVF fails or succeeds. We're going to start answering things in person here. I see a lot of people filling out some stuff, so thank you so much if you're filling it out. Appreciate that so, so much. All right.
And again, if you want to fill in the questionnaire, don't feel that because you fill in the questionnaire, you're going to be obligated to talk to me. You're not. It gets you in line. It's first come, first serve. So I urge you to fill it in, and fill it in while you're with me now. You can do it as we talk and as you hear.
Alright, perfect. We're going to answer Allison because I see them here just on the first page here. It says, "Hi Doc, I'm 41 years old with DOR. I am doing 300 units folism. 75-minute. I primed with estrogen and P." I don't know if it got cut off or if it means progesterone.
I hope you weren't taking progesterone. The estrogen's good. The progesterone being given before you start is not good. It's not good for the follicles and the eggs. So that's the only criticism I've got. Anyhow, go on, Josh. Any other questions?
That is the full extent of that question.
You are a typical example of what I've spent the last 20 minutes talking about. You have diminished ovarian reserve and you have the age factor. Giving you a protocol that doesn't direct itself specifically at regulating LH-exposed testosterone and avoid premature luteinization means that you're diminishing, in my opinion, your chance of being successful. No laboratory can take bad eggs and make good embryos. No laboratory. We've got to give good eggs to the embryologists who usually do a good job. And unfortunately, when things go wrong, often get the blame unfairly. It's much less likely to be the laboratory's fault if the embryo is bad than the protocol that was used for stimulation by the doctor getting the eggs to the embryo. So it's to the laboratory. So therefore, I can't emphasize enough why someone like you might well get some benefit out of reading the literature we provide and maybe taking your time now to fill in that questionnaire so you and I can have a debate.
Perfect. There's absolutely no reason you guys shouldn't go get the free articles, the free ebooks, everything he's got there. We're here every single week. We give out free resources and information. Dr. Scher has no malicious intent. He just likes to give information, and this is what we're here for. We're going to answer some more questions. Go ahead and comment your questions if you have any questions on IVF or pregnancy or anything to go with that lines. We're going to answer Kristen here on TikTok. They said, are there any circumstances where testosterone priming will help follicle synchronization?
I'm going to say, from my opinion, there'll be people that differ. My answer is absolutely no. I've just told you, too much testosterone is a bad thing. You need some of it. Now, if you're a young woman in your mid-30s and you've got an AMH that's sitting up there in the sky, you've got plenty of eggs available, it probably won't do any harm if you take a little bit of testosterone. There's another way for the testosterone to increase. I told you, use Clomid. Another no-no, in my opinion, with IVF. Although a lot of doctors will differ with me. That's my opinion for all the reasons I've given you. It's also a big no-no to use HCG. Oftentimes doctors give you a boost, prime you with HCG in the first part of the cycle. Guess why? Because they know, everybody knows, that testosterone converts to estrogen, that the follicle can only grow if that happens. What they don't take into account is that too much testosterone is the big evil and the thing that can cause a lot of problems. So you don't want to add more fuel to the fire by taking HCG, by getting more LH in the form of too much Menopur, by taking Clomid, by taking testosterone. These are all things that increase the fuel that creates premature luteinization. Now again, it probably won't do any harm when you're in your mid-30s in the middle of the bell, but it can do a lot of harm, in my opinion, to women that are older or have diminished ovarian reserve. That's where the word of caution comes in. And by the way, a lot of you, and some of you will probably want to ask the question, already have, what about DHEA? A lot of doctors will put you on this hormone, dihydroepiandrosterone, telling you that that hormone will enhance your ovaries' response. Again, dihydroepiandrosterone is a precursor of testosterone. The ovary gobbles it up, converts it to testosterone, and if you're older, or you've got diminished reserve or both, that's not what you want. If you're younger doing it, it's probably not going to help, but it's not going to do any harm. But it's not, definitely not, in my opinion, something I ever prescribe.
Alright, if you're filling out the form or if you're filling out the questionnaire to get the free ebooks here as well, thank you so much. I see all the push notifications coming through. Thank you. We're going to answer some more questions here. Comment your questions if you have any questions on IVF or stimulation protocols. We're going to answer Butterfly K here on TikTok. She said, are you taking new patients at 41 years old?
Of course. The bulk of my patients are everybody else's failures. I get people coming to me when they've thrown their arms up in the sky, or their doctor's throwing their arms up and doesn't know what's going on. That's the nature of our practice, is focusing on people that are spinning their wheels. Older women, women with diminished reserve, women with repeated miscarriages, women who have never been given the right explanation as to why good embryos that have been found to be normal even by PGTA are not attaching to the uterus. That is 80% of my practice. And my patients come from over 70 different countries. They come to me when they are really desperate. And that's why, and I know there are many of you there from all over the world. Doesn't matter where you come from. We can talk. You don't have to come to the United States for treatment. Some do, but you don't have to feel obligated. I'm there to give you information that will help you. And I will go as far as to say, even if that information is used by somebody else to help you, then I've done my job.
Alright, I'm going to answer Emily Red on TikTok here. This says, I was just diagnosed with unilateral hydrosalpinx. Do I have to do IVF after removal, or can I try?
You should do IVF because the commonest cause of hydrosalpinx is previous infection in your tube. Usually from gonorrhea or chlamydia. It can sometimes occur after an infection that occurred after a miscarriage or delivery of a baby. but it's almost always an infection that was transmitted, usually sexually. And if it was, here you can take this to the bank. If one tube was affected, both were affected. This is an equal opportunity bacteria. So if you get hydrosalpinx in one tube and the other one looks even open, doesn't mean it's normal inside the tube. The innermost, very sophisticated lining that's got to function perfectly for the sperm and the egg to travel with the right timing in the right directions to get where they need to go to meet, and then for the embryo to go back to the uterus, is very dependent upon the inner lining of the tube and the functionality of the muscle in the wall of the tube that enables it to contract like an earthworm. It's very, very important to understand this, so that if you've had a hydrosalpinx in one side, you can be almost certain that your other tubes also affected inside. And if that's the case, you're not going to easily get pregnant on your own. And if you're getting older and you don't have time, you haven't got time to waste, even if you're younger. The other problem is that because the inside of the tube may have been damaged, you're more at risk of having a tubular pregnancy or an ectopic pregnancy, which is no joke and can be life-endangering. For all of those reasons, I urge you to consider IVF as the treatment of choice for you, since you know one tube has been affected by something that's probably almost certainly also affected your other tube.
Alright, if you guys are just now scrolling and landing in Dr. Scher's live stream here, we're answering questions on IVF and the proper protocols for stimulation. If you haven't had your question answered yet, go check out our link in bio so you can have a conversation one-on-one with Dr. Scher. Takes 4 minutes of your time. You fill out a little questionnaire, ask a few questions about your experience here, and you will get a one-on-one conversation with Dr. Scher. There's also free resources for anybody who's in this live stream. They're exclusive for you guys today. There's an article that's in there. It will be gone at the end of this live stream. We take them down at the end of the live streams. So please, do yourself some justice and go grab that. There's so much information in those. Dr. Scher wrote it exclusively for you guys today. He writes an exclusive article every weekend for these live streams, so go check that out. There's free ebooks in there as well, and if you missed this live stream or want to replay it back, we post these every 48 hours on our YouTube, and now they will also be on Spotify, Apple Music, Amazon Music, and a few other platforms as well. All of that will be accessed in the link in bio, so go check that out. We're going to answer Safia on TikTok here. She says, what's your thoughts on omnitrope or growth hormone for diminished ovarian reserve?
It's not specifically for diminished ovarian reserve. It's a steroid. A human growth hormone. What it does is it augments the ability of the eggs that are in the ovary to develop properly. It can't make an abnormal egg a normal one, but the normal one has a better chance of getting where it needs to go. So using human growth hormone is something I do almost routinely with IVF, and it begins usually about a week or so before the period starts, before you start your fertility drugs. Something nobody asked tonight. If somebody's interested, maybe you want to ask it because it's a very common question. Maybe I should answer it anyway because it's so relevant. Many of you who are getting stimulated for IVF start on a birth control pill. Now, I know you do, but 90% of you that take a birth control pill take it, and when the period starts, the pill stops and you start taking injectable fertility drugs, Follistim, Gonalef and Menopur, and 7 or 8 days later you go into a regular antagonist protocol with ganirelix, cetrotide or orgalutron. I'm here to tell you that if you use a birth control pill like that, it will adversely affect your response to the drugs, and here's why. The birth control pill knocks out FSH and LH being produced by your pituitary gland. And that's good because you want to stop the LH before you start the cycle to give the ovaries a breather. So that's a good thing to use the birth control pill. But if you take it all the way through, it also knocks out FSH. And because it knocks out the FSH is a problem. There's got to be a rise in FSH before the cycle begins, because that rise in FSH causes you to form functional, what we call antral follicles. These are the eggs in a little fluid-filled space that looks like a small target. You can see it by ultrasound when the period starts, and you can actually see them. They're 4 to 6 millimeters in size. You can count them. The number of antral follicles you see tell you what the potential is for the number of follicles and eggs for you to be producing during that cycle of stimulation. So, but if you take the birth control pill, you suppress FSH and LH. And without that rise in LH before the cycle begins, the antral follicles are suppressed, and their ability to respond to the stimulation with follistim, gonadotropin, menopur is reduced. For the first 4 or 5 days that you then start on the drugs, those first 4 or 5 days, the follicles hardly grow. They start to become primed by the FSH you take in the fertility drugs, only to make them respond, and then they start responding. So it makes the stimulation protocol become longer in many cases. And it also makes the follicle growth discordant and irregular. You don't want to go on a birth control pill throughout a cycle, wait till the period comes and then be stimulated. Because the first 5 days of your stimulation with fertility drugs is taken up doing what should have happened in nature before your period begins by the rise in FSH. So what do we do to prevent that? We use Lupron. Lupron causes the FSH to go up. If you use a birth control pill, it's fine, because you can lengthen the time in the pill and shorten the time and have your period start on exactly the day you need. For some people, it's very important to know and have an exact calendar on when they'll be starting their treatment and their stimulation to work their lives around it. But for others, simply taking the Lupron from around the time a week before the period begins causes the FSH to go up, causes antral follicles to form. What I do is I put the woman on a birth control pill, doesn't matter how long you're on it, but for at least 10 days, overlap the pill with Lupron, stop the pill 3 days later, give them omnitrope, human growth hormone starting then, and they then continue with the Lupron and the omnitrope, and a period starts within a week. But now when the period starts, it's not going to be antral follicles that are lying dormant and not able to respond, because the Lupron has kicked up the FSH that caused them to be responsive, and now you'll respond immediately from the stimulation. It is not a good idea to use a birth control pill all the way till the period starts. Most doctors do, but in my opinion, it's not ideal. You can get away with it, and you probably get away with it more easily in the younger woman with normal ovarian reserve. But certainly for the older woman, for the woman that has got diminished ovarian reserve or both, you don't want to do that. You will stimulate much longer, you'll get poorer quality follicles and eggs. That's just a small little nuance which shows that it's not what you do, but how much and the timing of what you do that's important as the ingredients you receive. Everything I've told you uses the same drugs you're all used to using, but it's how you administer it. It's like a good baker making a cake. If you just put that same recipe in front of someone like me who doesn't know how to bake, you're not going to even eat what I make. But that same baker using it correctly with the right timing and juggling the temperature and when you take it out and what you do, you're going to get a good product at the end. It's the same as IVF. It's not what you use, it's how you use it, when you give it, in what relationship, and then ultimately when you trigger and what drugs you use for the triggering. Each patient needs a different approach to the trigger with HCG or with Lupron if you're going to use it, or a combination of both. We can talk about that if there are questions. But this talks to the important reason why the birth control pill will not suppress. It will suppress you if you use it the way it's usually used. And the doctor's correct, it does suppress. But if you use it overlapping it with Lupron, you don't get suppressed. And then you get the benefit of the birth control pill, lowering the LH and giving the ovaries a breather, and the benefit of the Lupron kicking your antral follicles into gear so you can start stimulation.
Alright, perfect. If you've been commenting for a minute and have not gotten your question answered, please go check out our link in bio. You can fill out that questionnaire that takes 4 minutes of your time, and Dr. Scher will answer you one-on-one in person. You guys can have a conversation. Exclusively to that, Dr. Scher has written an article for you guys today. It will be off of the website at the end of this live stream. So if you're in this live stream now is your chance to go get it. We've got about another 45 minutes left of our live today. We end at 4 p.m. PST. I think that's 6 p.m. 7 for the other coast there. So guys, you have a little bit of time left. Go get that article. Go get those free ebooks. Everything's there. The ebooks you guys can grab at any time during the week, but the article, it will not be there. So if you're interested in today's topic and what Dr. Schur has been giving you guys information-wise, I highly recommend you go check that out.
And if you feel that you'd benefit, I want to urge you again, please, for your sakes, get in line. We have first come, first serve on these consultations. I'm one person, I can't do everything. But if you get in there now and fill in those questionnaires, does not obligate you. You're not under pressure, but you're in line. And I will get to you. All you've got to do is fill it in, and it'll get to Patty. Patty will reach out to you, and you can decide. You don't even have to answer a call when she calls you. But at least you're in line. I don't want people calling me and emailing me as they do all the time and saying, I really want to get that consult and I can't get you in. So please do it. And if I can't speak to every one of you, I'll hand you over to Dr. Tortoriello. He and I have been working together for 20 years. We're two peas in a pod. We do things identically. You can't work together for that long doing the identical thing in the same location and not be identical in the way you do things.
Perfect. I see people filling out the forms and stuff coming through. I see the push notifications. So thank you guys so much. We're going to start answering questions again. If you have questions on today's topic about stimulation protocols or IVF failure, we can answer them right now for you. We're going to answer Sasha. She's been commenting for a minute here, so I want to get her answered. She says, AMH 23.3, 3 rounds of ICSI with 0 blast, 1 morula. I don't know if I'm saying that right.
How old is she?
No age on here, doesn't say. It says, does this indicate bad eggs? Sperm checked.
I'm so glad you asked this question. I thought it would never come. Think of that bell-shaped curve scenario again. Some people have got normal ovarian reserve in the middle, others got low, and others have got high.
29 years old.
Oh boy, you're right where I want you to be. Listen carefully. With that high AMH, you are a high responder. You fall in the bell-shaped curve where you over-respond. Now listen to me, everybody, very carefully, because they're more like this lady in the group, I'm sure. Women with low ovarian reserve and women with excessively high ovarian reserve have a propensity to form poor quality eggs for the same reason but needing a different treatment approach. Those with diminished ovarian reserve need a protocol that's more aggressive to get more follicles to grow, not a mini stimulation that's no damn good, not using Clomid, but they need a higher stimulation. Women with a high AMH tend to overproduce follicles. I have little doubt in my mind that this lady has overproduced follicles all over the ovaries and that she may even have a condition called PMOS, what used to be called PCOS. These kind of women with a high AMH make large numbers of follicles and are at risk of developing a condition called severe ovarian hyperstimulation syndrome. That's where all the follicles grow, and these follicles, by the way, for those of you that didn't know, don't only produce estrogen and progesterone and eggs, they also produce vasoactive substances, a substance called VEGF. Each follicle produces some. The more follicles you've got, the more it's produced. This causes the blood vessels in your pelvis to dilate and to become porous, so that the serum in your blood exudes through the blood vessels into the surrounding tissue, into what we call the third space, and can get into the pelvic cavity and the abdominal cavity, where it can collect as free fluid. We call that ascites, when the abdomen distends and fills with fluid. This happens because of the action of VEGF. And so it occurs when there are too many follicles present that are growing. The moment these follicles stop growing, because it's formed by the same cells that produce estrogen, if we stop those cells from producing estrogen, not only does the follicle stop growing as fast, but at the same time the VEGF production goes down. So if you overproduce VEGF, you can get this condition called OHSS, which is life endangering. No doctor, nobody in my field wants to see that, because it's a terribly difficult problem that can end up leaving you in hospital and can cost you your life. I haven't seen a case of OHSS in 15 years. And the reason is I developed a process called prolonged coasting. It's in my article that you'll get, and in the books I'm sending you. Prolonged coasting. Imagine you were on a boat rushing towards the rapids. What's the first thing you do? You take your oars out of the water and you try to pull to the side where it's not running as fast so that you can ease your way through the rapids easily. Those oars are the fertility drugs you take to make the follicles grow. With prolonged coasting, we watch the hormone levels go up. We count the number of follicles present so we know we're heading towards the rapids. Then we stop using at a certain point. It's all in the book, but I can't go into it now, there's no time. We take the oars out of the water, we stop giving you the follistim, the gonolef, and we just continue giving you the lupron that you're on, because for this condition, that's what you're on. You're not on the antagonist. And so now what happens is we coast slowly. We drift towards the rapids so we can go through easily. As soon as we see that we're not moving as fast, and the analogy there is the estrogen levels is reached at certain peak, we stop the drugs, now the estrogen comes down. And as it comes down, it's telling us the follicles, the granulosa cells that form the estrogen are not forming the estrogen anymore as much, and also the VEGF is going down. As soon as the estrogen level drops low enough, the follicles are large enough, now we trigger you with HCG and you won't develop OHSS. To be even more certain that you're not in trouble, we take the eggs, we fertilize them, we make embryos, we allow them to develop to the blastocyst stage where there are over 100 cells, and we do PGTA to know which embryos are normal. If you do the coasting, you will not get the bad effects of triggering too early, because many doctors who see this situation developing don't understand, they get nervous, so they trigger you with HCG before the follicles and the eggs have developed properly. So now the eggs are poor quality, and you're right. They're right, they tell you they're poor quality, but what they don't tell you is you're in poor quality eggs because of what was done. It's called iatrogenic. It can be avoided by doing the proper protocol. Again, here it involves prolonged coasting. So we can prevent OHSS, we can remove the eggs, fertilize them, make embryos, test them and store them, and get many, many more better ones by doing the right thing properly. And then come back a month or two later when you're not at risk and put in one at a time that are normal and give each one a 60% chance of making a pregnancy. At your young age, there's not a single reason why this problem can't be resolved, provided the protocol used for ovarian stimulation is individualized to meet your needs. You're on the other side of the spectrum. You don't have diminished ovarian reserve, you have excessive ovarian reserve, and one of the causes of that is PMOS, what used to be called PCOS, and the treatment is to treat you, watch you, use prolonged coasting, get more good eggs, and now you're in great shape. The doctor can go in and ligate it, or he can transect it, leave the tube in, but it doesn't make sense. Once it's got to be blocked, otherwise the fluid in the tube will leak into the uterus, damage the embryo we put in, and you're not going to easily get pregnant. So it's either got to be blocked permanently by transecting it or removing the tube. I suggest that if they are going in there, they remove the tube, because otherwise it can become infected and cause more problems for you later in life. And it doesn't take a lot more to remove the tube as compared to just ligating it. Now, if you've got tubes with hydrosalpinx, but there's so much scarring in the pelvis that they don't want to go in and do more surgery to resect the tube, then yes, just ligate it. And that's just as good.
Alright, I'm going to answer this one up here. I'm going to go back up. Thank you guys if you're filling out the form so much. Yeah, information is going to be super helpful. I see some more notifications coming through. Go fill out that form. We've got about 30 minutes left of this live stream before we take that off. That article that's specifically for you guys in this live stream today on this topic will be off of that website at the end of this live stream. The books will still be available. You guys can go check that out. The link is in our bio. If you're on any other platforms, it's in our bio as well. You can go fill it out. We're going to answer, let me go back up here. User 73 asks, can you please speak about endometriosis or endometritis, plus how to clear if doxy isn't working?
Well, first of all, Endometriosis means inflammation of the uterine lining or endometrium. Endometriosis, and I don't believe this, I know a lot of people will differ from me, and I respect that. I know a lot of you have done Emma and Alice testing and biopsies of the uterus for all kinds of evaluation of lymphocytes. I just want you to understand, in my opinion, endometriosis as an entity is only relevant if it occurred after a pregnancy occurred, after a miscarriage where some of the products retained in the uterus. Those products die, and there are bacteria in the vagina of all women that can grow in the presence of oxygen, because the cervix is just open to let the pregnancy out or to have the pregnancy extracted from. These bacteria swim through the opening of the cervix, which they ordinarily can't get through because there's mucus that blocks their way. They get into the uterus, they go and invade in the dead tissue, and they spread like a forest fire. They damage the lining of the uterus, including the roots that provide the estrogen, the roots that the estrogen reaches for the endometrium to grow, and now you don't get a thick enough lining. Sometimes you even get scar tissue and adhesions in the uterus, and it can be so bad you can get a condition we call Asherman syndrome. So if there's been endometritis after a pregnancy, be it after the birth of a child, where some of the placenta was retained inside, if it occurs after a miscarriage, even if it occurs after an abortion, or after a hydrotelliform mole, that dead tissue can then support endometriosis. When that happens, it destroys the uterine lining, but it's not there permanently. Once you start menstruating again, when you menstruate, you purge your lining every month. So what happens is that the lining gets purged, and the blood of the menses, some of it has got antibacterial properties, so it kills bacteria. So I don't believe there is an entity such as endometritis that can cause problems with chronically through infecting the uterus. I do believe endometritis, once it occurs, can permanently compromise your ability to implant a pregnancy because it's destroyed the soil in the plantar box that allows the embryo to attach. But there are ways, and I've written up on this, and you'll find it in the book as well. Even if the lining is thin because of a previous endometritis, we can treat it with vaginal sildenafil or Viagra, compounded specially so it absorbs properly, which then opens up the blood vessels to the lining that's been damaged and can improve the blood flow and make the lining thicken again in more than half the cases. So there always are things you can do if the lining's thin, but endometritis as an active cause of preventing an embryo from attaching doesn't occur every month when the woman menstruates. She purges her lining, and if there's been any bacteria in there, and they can't easily get through the cervix to get there, unless the cervix was open during a pregnancy or delivery or a miscarriage or an abortion, if that happens, you're not going to be in trouble because the uterine lining purges itself and cleanses itself every single time you have a menstrual period. There is one extremely rare cause of chronic endometritis. I've seen it in Africa when I worked there. We're going to see more and more of it as we get more immigrants coming into the country. But you, as a practicing fertility doctor, we maybe see one every 2 or 3 years. It's called tuberculosis of the uterus. Extremely rare. But if that occurs, that's a bad situation. You may not be able to resolve it, and then you need a gestational carrier or a surrogate if you can't fix it. Obviously, if you get it early enough, you can treat with anti-tuberculous drugs, and like rifampin or isoniazid or streptomycin or various other drugs which get rid of the infection before it takes hold. But if it's already taken hold and damaged the lining permanently, you're not going to be able to fix it, and then you need a surrogate.
Alright, if you guys are filling out the form, just want to say thank you so much. Hopefully you guys will have a conversation soon with Dr. Scher, if that's the plans. If you're filling out the form here, go ahead and get those free ebooks and articles. There's about 30 minutes left that you guys will have them, so please go check them out. They will not be here at the end of this live stream. Dr. Scher wrote them specifically for you guys today and this topic, so go check out that article. He writes a new one every week. If you've been in the live stream for a minute or didn't get to catch the earlier part of it where Dr. Scher went really into depth about stimulation protocols, this video, along with all our other podcasts, get posted onto YouTube. You can look up the YouTube either in the bio, or you can search up at Dr. Jeffrey Sure on all platforms. At Dr. Jeffrey Sure on all platforms, you guys can find the repost of these live streams.
And that'll happen in about 48 hours, right?
Typically, we post those in about 48 hours. Also, our live stream podcast will also be up on Spotify and Amazon Music and a bunch of other platforms soon here as well.
And by the way, today is the first day that's possible. We only just went onto those other platforms, which I would like to ask a favor. I would like you to please spread the word around that we're on these platforms. I'd like you to spread the word around about these webinars. Next week's webinar that I'm going to do is going to be on immunology. Who needs immunologic testing, and why, and how do we do it, and how do we solve the problem? Because immunologic problems can prevent implantation. It's going to be a very popular webinar. So please spread the word through your various forums. Many of you are in groups. Tell people to come to this forum and join us. The more the merrier.
Awesome. We're live every week at 2 to 4 p.m. PST, so go ahead and check us out. We have a new topic every week. We're going to answer a few more questions here with our remaining time, so please comment your question if you have any questions on IVF, on stimulation protocols, or why IVF can fail or succeed. We're going to answer Roxy. She's been commenting for a minute now, and I want to get her question answered here. It says, "Hi doc, please answer my question. 33 years old with POI diagnosis. What is your recommendation?"
Are you saying that you have premature ovarian failure, POF?
POI. That's what I have here.
POI. Can you write it out? Tell me what you mean.
Roxy, go ahead and write out what you mean with POI. She said yes, but I don't know if that's the answer to that.
Are you saying premature ovarian failure, yes or no?
Premature ovarian insufficiency.
Oh, that's the same thing. Okay. So, the question was, what can you do about it?
Says she's 33 with POI diagnosis. What is your recommendation for
Well,
her?
if you're in the menopause, it usually means there's not much we're going to be able to do. We can try. There's certain stimulations which may reawaken the growth of 1 or 2 follicles and still get an egg that can make a baby. POI can also be caused by genetic causes which we can't traverse. So it all depends on the cause of the POI and how severe it is. And if you're telling me that you have premature ovarian insufficiency, which is progressive, but you're still bleeding, even if it's irregular, there may be something we can do. But the good news for you is you're still young. So your eggs, still 2 out of 3 should be normal, provided we use a protocol that doesn't compromise them. I've hammered this over and over. We have to use individualized protocols. You can't use recipe approaches when you deal with diminished ovarian reserve. It all depends on how severe that diminution is. If you're not having periods and you have never had periods, probably nothing we can do except offer you the option of using egg donation or embryo donation. But there's always something we can do to help you have a baby, even if it can't be done with your own eggs. The only way I can help understand what to do for you would be to have much more information, which is impossible to get in this forum. I urge you, fill in that questionnaire, get it to Patty, or email her. I left my email address earlier on. Email her and she'll get you in quickly, because I think you've got a desperate situation. Time is your biggest enemy, and I would like to help you if I can.
Alright, I'm going to answer Crystal Irene. She's been commenting for a minute now, and she's also our number 3 viewer of today. It says, "I have a BCL6 and had a failed transfer after doing suppression. Would you recommend laparoscopy surgery?" Question.
No to both. You don't need suppression and you don't need laparoscopic surgery. The BCL6 tells us you have a 90% chance of having endometriosis unless you have a large fluid-filled tube on either side, hydrosalpinx, and if you don't, you've got endometriosis. Endometriosis will prevent you from getting pregnant through a variety of mechanisms. Even if your tubes are open and normal, even if it can't even be seen through the laparoscope yet, it starts off being invisible and then it becomes visible. You don't only have endometriosis when you can see the lesions, you have it when you're in your teen years already. Many women like you present with unexplained infertility first, and only later on they find out they've got endometriosis. Endometriosis reduces the chance of getting pregnant per month of trying, even if it's invisible and it's preclinical, by a factor that is dramatic, 5 times less, because it creates a toxic environment in the pelvis, and as the egg leaves the ovary to reach the tube to fertilize the egg, it gets compromised. And that's why women with endometriosis, instead of having at your age a 20% chance of a baby per month and 80% in a year, end up with a 2 or 3% chance in a month and maybe a 40% chance in 5 years. And it can be 0 if there are further problems, such as if you've got an immunologic problem that affects the ability of the resulting embryo to implant in the uterus. And that immunologic problem requires testing in one of 3 labs in America. Regular labs can't do the testing sufficiently and efficiently enough to be of value. So it becomes really important to know, do you have the immunologic problem? In your case, again, like in the previous cases I've spoken to, doing surgery is not going to improve your chances of getting pregnant. Even if you've got a cyst in your ovary with chocolate fluid called an endometrioma, you no longer need surgery to remove it. We do a thing called sclerotherapy, where we drain the fluid from the cyst when you're awake or under local anesthetic or under conscious sedation. We inject something into the cyst that causes it to collapse and disappear. Problem gone without surgery, just as effective, if not more, than surgery, and it doesn't damage the ovary and destroy some of your eggs as surgery would. So the days of doing for infertility related to endometriosis, doing laparoscopy or doing Lupron suppression are gone. You don't need either. I've done a webinar on this. I did one, I think, last week on this very topic. If you go to YouTube, you can go watch it, get all that information, or you can read it up in my book that I've sent you. So, for you, no Lupron, no surgery. Treatment can fix your problem once we know exactly what the components of it are, and like anything else, you've got to identify, quantify and typify the factors, because endometriosis can affect your ovaries and it can affect your ability of your uterus to implant the embryo. We have to focus on the cause and with targeted treatment help you solve your problem and have a baby without too much difficulty. But you do need IVF.
Alrighty, if you're just now scrolling in, we're answering questions on IVF and stimulation protocols and why IVF can fail or succeed. If you've been commenting for a minute and have not had your question answered, go check out the link in bio and fill out a form. You can have a one-on-one conversation with Dr. Schur. It takes 4 minutes of your time. If you've been here for a minute and just love the information you're getting, or maybe you didn't see earlier information that Dr. Schur gave, we post these live streams every week on YouTube at Dr. Jeffrey Schur on all platforms. So go check that out. We have about 20 minutes left, so it's, in those 20 minutes you can get the article that's on the live stream right now. It will be off of the live stream at the end of this. It will no longer be accessible, so go check that out. I highly recommend everyone go check it out.
And every single one of you here, there's not a single reason why you shouldn't get the books and the articles. They are free. All you got to do is click on that link, click on my picture, go to my bio, get the book, and then read it or burn it, do whatever you like. But get it while you still can. The article's not going to be around for long, and it's going to give you a lot more insight than you obviously have had based on the questions I'm getting. Please do that. And then for those of you who are still on this pod now, on this webinar now, I urge you, go and get that questionnaire by clicking on the bio. The questionnaire doesn't put you under any pressure, but puts you in line to be able to talk to me if you think it would help. If you don't think it would help, no need. But if you think I can give you some insights into your problem, doesn't mean you've got to come to me for treatment. It simply means you get in line and we talk. And you will, by clicking on that link, be assured you'll get a phone call back from Patty, my office manager, within the next 48 hours, or by Tuesday, and Patty will set you up if you choose to talk to me. There's no pressure, no solicitation. Don't lose the opportunity to talk, because it's first come, first serve. Please go and do that, and do it while you're on with me now, so you don't lose that opportunity. Please do it now.
Awesome. For the last 15 minutes here, we're going to continue answering some questions from you guys. I'm going to answer Naomi here on TikTok. Says, I'd like to know the advantages of antagonist protocol after 3 IVF failures.
That's an impossible question to answer because I don't know why you failed. Did you fail because the embryos were bad? If you did, the antagonist protocol done conventionally, if you've got diminished ovarian reserve, is not ideal for you for all the reasons I gave you when I spoke earlier on, and you'll find on this webinar when you go back onto one of the platforms and listen to it. You can't use a one-size-fits-all protocol. If you've got diminished ovarian reserve and there's an age factor, that could be the reason. You can't blame the protocol alone. It may be the protocol, but I'm not in position to answer you until I know much more about you. So therefore, in your case especially, I think it's in your interest right away to fill in that questionnaire and put your name down as a possible contact by us so that we can, if you're interested, arrange to have a chat, you and me.
Emoda on TikTok says, what protocol do Hashimoto's patients need with DOR age 37?
Interesting you asked that question. Patients who've got Hashimoto's disease have got an autoimmune condition. Their biggest problem isn't so much their eggs as the fact that 50% of women who've got antibodies to their own thyroid, which Hashimoto's patients do have, will have an immunologic implantation problem in the uterus linked to certain cells called natural killer cells, which become activated in 50% of those cases, attack the embryo and destroy it. We can fix it. I have a patient that I spoke to when I was in Australia, in Melbourne, giving a lecture. She and her husband came up to me. She was 42 years of age. Her AMH was 0.2. She had had 24 failed IVFs. And the reason was that she had embryos put in her uterus over and over that couldn't touch sides because of the antibodies, because of the natural killer cell activation that prevented them from attaching. She and her husband came to the United States. I'm now the godfather of their child. After one try. The second issue you mentioned was DOR. It's very interesting that a lot of women who've got thyroid problems often have ovarian problems as well. I don't know why, but it is so. You may have diminished ovarian reserve. Get that article that's on the bio. Read it. Read the articles in my books that you will also get. The book, by the way, that thin one that is on immunology, talks about Hashimoto's as well. Read these things, and then if you're wise, arrange a time when you and I can talk so I may be able to be of some good to you. All you got to do is get that questionnaire, fill it in right now, and let Patty reach out to you in the next couple of days.
I'm just going to read this off. This is a cute one. It says, hello doctor, how are you doing? That's from Monique.
I'm doing great. Thank you all for being here. You made my day. I love what I do. I wouldn't do it if I didn't have to, if I didn't love it, because I don't have to do it anymore. It's my passion. Everybody has a passion in life. This is mine. And the more good I can do, the better. If I can't do good, I don't want to be anywhere near that person, because there's a thing called the Hippocratic Oath. Do no harm. I don't want to do any harm to anyone.
All right, I'm going to answer this question here. They've been commenting for a minute. I don't know what that symbol is, so I'm so sorry, but 12 here on TikTok says, hi doctor, 29 years old, several GTP-tested embryos transferred to and didn't implant. Please advise for next time.
Sounds like you've got an implantation problem. Your problem is sitting in your uterus. Somebody's missing it. There is an immunologic or an anatomical cause. You've either got a thin lining, you've got a uterine lining that's under 8 millimeters at the time you ovulate, or at the time you get HCG for the trigger, or at the time you get progesterone for a transfer, or you've got an irregular surface inside your uterine lining where there are polyps, like little mushrooms growing into the cavity that's irritating the lining and rejecting the embryo, or fibroid tumors in the wall growing into the uterus, or scar tissue from a previous post-pregnancy infection, or you've got the immunologic cause where you've got activated natural killer cells, which I just mentioned a few minutes ago. I can help you with this in that thin book that comes to you free. In the first 2 chapters will explain the immunologic issues. But I'm pretty sure I can give you some pretty good ideas of what to do. Arrange through the questionnaire to talk to me and I'll try. But in the meanwhile, I don't think you're that much of a tough case. If you're making good embryos, you're going to have a baby when we fix the reasons for implantation. We've got to identify, quantify, typify them and address them, and they've all got solutions. Otherwise, it's like going duck hunting, wanting to have a roast duck for dinner, but only shooting where you hear quacking and not taking aim. We got to do that. And we can do that. I urge you guys to do what you need to do to get in front of me and let me help you.
Perpetual on TikTok, you're asking about Dr. Scher's contact. Just go to the link in bio, fill out the 4-minute questionnaire, and he will get in contact with you guys.
How do I get onto that bio?
You simply click on Dr. Scher's face at the very top, and the link will be there in our biography at the very top of the page, and the link is at the very bottom of it. You click the link and it'll take you right to the page. All Dr. Scher's information will be there. You guys can exchange contacts, and you guys can have a potential conversation together. We're going to keep answering some questions here for the last 15 minutes that we have here. It's almost about 10 minutes now. You guys have almost 10 minutes left to go get that article that Dr. Scher wrote on today's topic about stimulation protocols. Highly recommend you go get it because it's not going to be here at the end of this live. So you have 10 minutes left. Go get that article. The free ebooks will still be there. You guys can grab those anytime during the week. But our articles are only exclusive for Saturdays on these live streams. So go check it out. It won't be here for much longer. Got about 10 minutes left, so please answer or drop any questions you have on IVF, or maybe it's something recent that's happening with you guys in pregnancy. Comment it and we'll answer the best we can here. B28 is asking, where's your clinic? Can you share where your clinic is?
Our clinic is in Midtown Manhattan, and my patients come from more than 70 different countries. They come to me and to Dr. Tortoriello, and we work like two peas in a pod. And you only have to spend about a week with us, maybe less. All the preliminary testing and preparations done at home. We bring you in and we work in many cases with your own OBGYN to get most of the stuff we need done there. We help you with transport, we help you with accommodation because we're well located, been there a long time, and we know all the hotels that give special rates and what you can do. So it's in Midtown Manhattan. It's called Scher Fertility Solutions, SFS. You can go to our website at scherivf.com.
Perfect. We're going to answer Joanne here. She's been commenting for a minute. She says 39, 8 eggs collected, 6 mature, 4 fertilized.
Can you repeat that? I missed that.
39 years old, 8 eggs collected, 6 mature, 4 fertilized. Is this good freeze all cycle on Wednesday if any make it?
It all depends what your estradiol was, how many follicles you had, whether those 8 are 8 of 8, 8 of 10, or 8 of 28. So I can answer your question about how good that is. It's good to have those eggs that are mature. Doesn't mean they're going to make normal embryos. Remember, at 39, only about 1 in every 4 are going to be normal. So if you end up with 1 or 2 that are normal, you've done good. If you had more eggs and you could have had more eggs extracted, not so good. If your AMH was over 2 or over 1.5, you should probably have had a lot more eggs than that. Whatever your estradiol level was in picograms per milliliter at the peak on the day that you got the trigger shot, divide that number by between 150 and 200, and that should let you know how many eggs there should have been.
It says 14 follicles is what she commented here in addition.
And what was the estradiol level at the highest point on the day before you got the egg retrieval? Do you know how high it was?
No answer yet.
Well, you'll let me know.
We'll do. Alright, we're gonna answer. We'll give it a second here, hold on. Joanne, if you know that information, she says, what number is that? 11,000 is the number. 11,000? I don't know if there's a mistype on a 0 there, but 11000.
Is that 11,000 picomoles per liter? Or do you live in Canada? Live in the UK? Or is it picograms per milliliter? PG/ml or PMOL per liter?
Give it a second here.
I'll go an extra 5 minutes if I have to.
UK PMO.
Okay, so it's about 3,000. You should have had, it's about 4,000. So you should have had about 25 eggs, 25 follicles. The fact that you had 14 means that a lot of them weren't grown properly, which raises the question, how was your stimulation? Was it an ideal protocol? I don't know. How long did they stimulate you for? But you should have had 25 follicles around that point. Maybe the doctor was nervous you'd get overstimulated and triggered you early, and if you triggered early, many of the follicles don't yield their eggs. You often hear doctors then say to you, you know, the follicles were empty. There's no such thing as an empty follicle. All follicles got eggs that can't grow if they don't. because the egg is like the conductor of the hormonal orchestra. So if that's what you had, it's not so hot to have had 8 eggs.
359 IU, and then Menopur, it says 11 days on it.
Okay.
Those additional
So,
information.
the number of eggs, the number of follicles, the number of eggs you got, the number that are mature, don't jive. It seems you could have done better, I think.
I'm going to go back up here. Jessica on TikTok says 4 early losses, 3 PGTA tested embryos came back normal. How likely a transfer will work?
Not unless you find out why they're not attaching. If you've got good embryos that are put in the uterus and they're not attaching, you've got an implantation dysfunction. Implantation dysfunctions can be, as I told you, immunologic. They can be anatomical due to a thin lining, or they can be due to an irregular uterine cavity. There are other things as well. In some rare cases, they're due to genetic problems called translocation disorders and a variety of other genetic causes. But in most cases, those 3 things I told you, a thin lining, irregular cavity, which you can only test by doing a saline sonogram or a hysteroscopy or an MRI, or there could be immunologic causes which most labs can't test for you. They've got to be done in one of 3 labs in America that can do these tests with adequate sensitivity and specificity. Read that thin book I sent you. It's about recurrent miscarriage, and the first 2 chapters will give you the answers. But then after that, take your time, download that questionnaire, answer the questions, and if you want to, reach out to me and we can discuss your situation. I'm pretty sure I can help you. Pretty sure, given the fact that you make such good embryos.
I'm going to answer an Armstrong 105 here, but right before I do that, I just want to thank everybody for giving their notifications here. I see a lot of people filling out the forms. Guys, only 5 minutes left of this live stream before we end it for the day. Thank you guys all for being here so far. We really appreciate all the comments here, but 5 minutes left to go get this article. Dr. Sher wrote it specifically for today about today's topic. He writes a new one exclusively every Saturday for you guys. It will be off of the live stream or off of the website here at the end of this live stream. So there's really no reason why you guys shouldn't go capture it. It's free of charge, all there. Nothing that we ask of you. And if you want to have a conversation, I see a few of you are asking for Dr. Sher's personal information or to have a private conversation. That's the way to do it. You go to the link in bio, you fill out a 4-minute questionnaire, and it goes right to his inbox, and he gets back to you within the next few days here. It's your placeholder in line, so you guys can have an actual conversation one-on-one with Dr. Sher. So go check that out. There's so many resources in our bio. If you guys missed today's live stream, we post these after about 48 hours onto YouTube, and now they will also be going up onto Spotify and Apple Music, and Amazon platforms as well, so you guys can get access to the audio version of this as well. We're going to answer back up here.
And please spread the word, please.
Yes. Please share this. We're here every Saturday from 2 to 4 PST.
There will be some times when we won't be a Saturday, it will be a Sunday, but we'll give plenty notification in advance if I'm not available on that Saturday.
Alrighty. We've got a few more minutes left, so please comment your question. We're probably going to answer about 1 more question here, maybe 2, but we have a few minutes left here, so go ahead and comment it. Whatever I see the most here, we'll answer. Go ahead and spam your comments if you have any. Answer your questions here. We're answering questions on IVF and specifically about the stimulation protocols that go into it. Go ahead and drop your comment here and we'll answer you. Perpetual will DM you. Sometimes people in other countries have a problem opening up that link or that side of it, so just we'll DM you and get you the proper link. Don't worry, we'll hit you up right after the live stream. Go ahead and comment, guys. We have a few more minutes left. We're going to answer 1 more comment. I think this is a good one. One more time, Dr. Sher. Can you please explain the antagonist protocol?
Okay. My patients, and there may be variations on this theme, and it very much depends upon your AMH as to how much of the drugs we give. Let me give you a little quick walkthrough. You'd start the birth control pill for at least 10 days. I would then overlap the pill, and these are combined pills. I'd overlap it with Lupron, Buserelin, Superfact, Decapeptyl, they're all the same GnRH agonists for 3 days. Pill plus birth control pill, and I'd add Omnitrope. After 3 days, I'd stop the pill, continue with the Lupron and the Omnitrope every day, usually 10 units of Lupron, and then you have a period within 6 to 8 days
The moment you have your period, we send you to have an ultrasound to make sure there are no cysts in the ovaries, and also to make sure that and you do a blood test to make sure your estradiol level is low enough to be at baseline and you can start. Usually in America that's a level of estrogen of less than 70 picograms per milliliter, and in Canada less than 200 picomoles per liter. At that point you would start with a dosage of Follistim, Gonlef or Purigon, which I can't tell you how much because I don't know your AMH, and 75 units of Menopur for 2 days. On the third day we'd halve the dose of the Follistim, Gonlef or Follistim or Purigon, and maintain the dose of 75 units of Menopur. You'd continue doing all this at home. You're not in New York. You get all these shots at home under our direction. Working with our nurses who are in touch with you and they're on you stuck to you like glue. And then on the 7th or 8th day, we start doing monitoring. You don't need it before. A lot of doctors do monitoring early on. It's a waste of time. You need it from approximately 6 days of taking the Follistim, Gonlef, Purigon. And now we've switched you from the Lupron to Ganirelix or Cetrotide. You started that on the first day of starting the Follistim, Gonlef or Purigon. You start with 250 micrograms of Ganirelix or Cetrotide or Galutron. On days, and you keep on that all the way till the trigger shot. Now we follow you. You arrive in New York when you're around day 7 or 8 of your cycle of stimulation, having dropped your dosage of fertility drugs. We do daily ultrasounds of blood estradiol levels to see when you're ready or adjust things. That's where the seasoning comes into it. And as soon as your follicles, you have several of them between 18 and 22 millimeters, and half of all of the remaining follicles are over 15 millimeters, and the blood estradiol coincides with the number of follicles over 15 millimeters. It tells us exactly when you're ready to be triggered. We give you 10,000 units of Pregnal, Profaci or Novarel, or 500 micrograms, which is 2 vials of the recombinant HCG of a drug. And then 36 hours later, we take you to the operating room. An anesthesiologist who's had a consult with you puts you under conscious sedation. While you're asleep, we do inspection of the inside of your uterus at no extra cost, called a saline sonogram. And we also measure the thickness of your lining to know what it's going to be like when we come to transfer your embryos in a later cycle. And then the next morning, then we take the eggs when you wake up. We tell you about your lining, tell you about your uterine cavity, if it's normal, and we tell you about how many eggs you got and what their quality appeared to be microscopically. We then do ICSI, inject 1 sperm into each egg, and this is done that same day. You go home the very next morning with your husband, who doesn't need to be with us in New York for more than a day. We need you for a couple of days. He's welcome to be there, but we don't need him for much longer. And then what happens is we stay in touch with you, letting you know exactly how the fertilized egg is dividing. Those that make it to blastocyst, if you need it, you may not need it, but you may need it. If they make it to blastocyst by day no later than 6 days after the ICSI, we biopsy them through PGTA, and we test the chromosomal makeup of your embryos for those that need it. Not everybody needs it. And then it takes 12 days to get the results. The moment we get the results, you and I get on the phone, we discuss the results, and we decide what we're going to do with those embryos. How many are male, how many are female, how many are normal, how many are mosaic, how many are abnormal. We keep the normal and the mosaic ones, the rest we discard. We discard the ones that never made it by day 6. And then we decide together, do you want to do another cycle to bank more embryos to make hay while the sun shines, or do you want to put them back? Either way, we then talk about when do you come back for 3 or 4 days to New York to get a transfer, working with your doctor at home, and we give instructions and directions and everything that goes with it, and it all flows from there.
Cool. Alrighty.
I think we've done it. I just want to say one thing before we leave. From my own personal perspective, I appreciate every single one of you for taking the time to listen to me. Nobody in my family does, so it's really nice to have you there to listen to me. Thank you very much. I appreciate it. I enjoy it. That's why I'm back every week to do it over and over with new topics. I ask you to please stay in touch. If you need me, you know how to reach me. If you want to just get the information, you know how to get that. I ask you also to spread the word around. When we get large enough and we're developing a big following, when our following is large enough, I'm going to start doing live podcasts, inviting guests to come in and join on separate dates. I'm going to move into that and do it a lot more. I can't do it till we're large enough. Please, many of you are in groups of infertility patients or people with repeated miscarriages, which is a big area of my interest. My main areas of expertise lie in the genetic PGTA testing, which Dr. Tortriello and I introduced into the field, and in the field of clinically reproductive immunology. And so, if any of you are having unexplained IVF failure, unexplained miscarriages, if any of you got immune disorders in your family or in your personal history, I'm the right stop for you. I urge you to spread the word around so others can come and join in on these discussions. We can grow quickly, move into the podcast realm, and I can hopefully do more good than I'm doing now. Thank you all so much for attending, and I wish you all a happy rest of your weekend.